Good evening.
Hi, good morning. Is it Dr. Springer?
Yeah. Shannon, how you going?
And yeah, good, thanks. I'm Chris from OzTREKK.
Yeah, nice to meet you, Chris.
Likewise. Thank you for making time. Um, everyone is joining the call right now. So I was just going to do a quick laying of the ground rules, and then
Yep,
we
sure.
can get into it. How does that sound?
Yeah, sounds great.
Okay, very good. So welcome everybody. Good evening, depending on what part of the world you're in, or good morning. Like Shannon in, I assume in and around the Gold Coast, Australia. So thank you for joining us for this session from Griffith University. And just some ground rules. My name's Chris Nolan. I'm one of the owners at OzTREKK, and I'm the director of recruitment and outreach for us. And so we're going to have to be a little rigid in terms of the 15-minute window, because there are sessions immediately after. And in fairness to everyone, we need to respect the schedule. There will be an opportunity to ask questions towards the end. And if all the questions inevitably don't get answered, we're definitely going to be available. Our admissions team in the OzTREKK booth, as well with Career Echo, as well as several representatives from Griffith University are going to be in their booth, and we can get your questions answered. So without further ado, Shannon, I'll pass it over to you.
Thank you. I just would like to share my screen, if that's okay. Host disabled participant screen sharing. Is it possible to do that? Chris, oh, there we go. Yep, thanks.
We can see that, Shannon.
Yeah, you can see that. And you can see that clearly, just the screen there, or you can see everything?
Yes, we can see.
Okay, great. All right, well, thank you for asking me to have a chat today. I will introduce myself in just a few moments. Before I start, as customary with the university and my own cultural obligations, I would like to acknowledge the Yugambeh peoples on the country that I am speaking from today, and I'd like to acknowledge their elders, past, present, and emerging. I would also like to, at this point, acknowledge the responsibility of their custodianship, and they haven't relinquished their responsibility for looking after the country in which we walk on today. I would also like to acknowledge all of you and all your families and your connections that you have, and pay my respects to your ancestors and your stories, because we shouldn't leave our stories of who we are at the door, because it's what enriches humanity, and it also what enriches our education as well. So thank you again for allowing me to have this conversation with you today. A little bit of background about myself. So I am an Aboriginal man from North Queensland in a place called Mackay. And I originally went through school to become an Aboriginal health worker, well, more so to play football, actually, to play rugby league. And then I finished my 3-year Aboriginal health worker course, and then went on to do medicine after that. I'm situated on the Gold Coast on Yugambeh land, and by background, I'm a general practitioner, so I'm a fellow with the Royal Australian College of GPs, and working also as a GP in a remote Aboriginal medical centre called Charleville. I'm also recently starting to do telemedicine to maintain my connection with that place and practice there as well. Today I wanted to talk about 3 main things. The first thing is the context of First Peoples health education in the medical curriculum, both here nationally and internationally. Look at some of the challenges and changes that we've seen with delivering First Peoples health curriculum over a long period of time, which I've been involved in this area, and how we've adapted and how we're going to change that at Griffith University to provide excuse me, a premium First nation's health product for 2021 and beyond. So a little bit about the context. In 2015, I traveled to Canada, on a conference, and it was a conference where we were hopped on a bus and we moved from community to community. And this particular conference stopped at from Sudbury on our way to Sault Ste. Marie, and there's a little town called Spanish. And here we sat and spoke with one of the elders of that place, and they talked about their stories of being removed from country and being removed from their families. And this was in 2015, when at that time, under the Trudeau government, I don't know who's in power at the moment, were the Truth and Reconciliation Commission were doing their delivery of their report. And it was a real eye-opener to myself how similar our histories in terms of the First Peoples Health of Canada and those of my own were so similar in what we experience in terms of colonization. And also to add, so the Truth and sorry, just get the little laser going here. The commission released their findings in 2015. We had a similar report that was released in 1997. So we were some way ahead of what was happening in Canada. So that's just some of the social context around that. Also, I wanted to acknowledge our other connections that I have. So I'm part of PRIDOC, which is hosted by the Indigenous Physicians Association of Canada, and I've had a lot to do with Barry LaValle. Some of you may know of him, and also OzTREKK, through Tiora, which is the New Zealand Māori Association, and the Association of the American Indian Physicians, and I'm recently the past Vice President of the Australian Indigenous Doctors Association, and we've also had meetings with the Medical Association of the Indigenous People of Taiwan. So that just gives you an international perspective of some of the circles that we've walked in the past. In terms of providing further context around medical education, there are standards set by the medical profession, both here in Australia and also in Canada, which really outlined what the medical profession has to do in developing the doctors for the future. We've had standards since 2006. When I was in Canada in 2015, a lot of the standards spoke more about social accountability rather than those factors around First Peoples Health in particular. To give you a little bit of a little further context, in the early days of implementing Indigenous health curriculum, it was really difficult to get Indigenous ways of knowing and being into the actual the ways of teaching medical education. So Rich is really predominantly a biomedical sort of model. So we had made lots of mistakes both here and internationally about reinforcing a lot of stereotypes about Indigenous people, and that's because we had no leadership within the institutions. So often the content was more around disease prevalence and incidence. It was very deficit focused and disease focused. It had some really narrow perspectives around the social determinants of health. We looked at cultural difference, and we also looked at research was really done on Indigenous people rather than with Indigenous people. In terms of the institutional content, it was often taught by non-Indigenous people. Often Indigenous people were brought in as guest speakers and were really burnt out about that. And then we took people on immersions, which was really more a tourism type experience. So we made sort of lots of mistakes in the past, and as a medical student, I was sort of was to bear witness of some of these mistakes. What we tried to do with people like Dr. Chelsea Bond, who's an academic and a forward thinker, was really to try and flip this narrative on its head. And the solution to racism is not about cultural awareness and about teaching people about indigenous cultures. It's really looking at critical race theory and developing a consciousness around that. So in order to be an effective contributor or to make better doctors, medical education institutions, we had to engage in a decolonization process, and we had to address racism and privilege at a curricular and both institutional sort of level. So some of the concepts that make a good First Peoples Health curriculum in 2020, we have to have the social and cultural determinants of health. We must talk about that. You know, we often talk about housing, education, employment, and those sorts of things, but what does it mean to have a strength-based culture in terms of assisting people get both better lives for themselves and for their families? We have to have a strength-based approach. So what's doing well in people's lives and how do we develop those sorts of things with culture at the center? We must challenge the deficit narratives about Aboriginal people and Indigenous peoples. Challenge what people thought they knew about Aboriginal and Torres Strait Islander peoples in the Australian context, but also in the Indigenous context elsewhere. And we have to have a sophisticated understanding about how racism works and operates to maintain the powers and the resources and the health inequities that we see across Australia, but also abroad. We also need to see some of the learning that we offer as transformative to being better human beings. So this will not only make you better health professionals, but also you'll be able to advocate in whatever scenes that you walk and whatever realities you walk. And we have to have leadership advocacy and also effective affect change. What we can see is here is the continuum of learning. In medical school, we start with cultural awareness, so understanding the difference, understanding how our cultures influence the way we see and interpret our realities. We have to understand the cultural determinants of health. We have to look at racism and the way it operates, particularly on the institutional levels, to marginalised people and access to healthcare. And we actually also have to acknowledge social and emotional well-being. And this is from the Australian context, that we have a lot to value. We have a lot of value-adding concepts around health and well-being for the medical profession. And hopefully that will make us culturally safe and develop culturally safe institutions, and also develop institutional changes where Aboriginal people or Indigenous people are more likely to get an investigation when they present to medical services. So hopefully, if those of you that will study at Griffith University in year one, we'll take people from cultural awareness, look at some of the historical influences, and we'll also look at the influences and similarities around the world. Look at the political, social, and determinants of health and actually apply that. And then we will look at principles to work with and for Indigenous peoples. In year two, we'll look more critically around racism and look more about developing research principles to work with Indigenous peoples and developing culturally safe systems. In year 3 and 4, we look at application to practice. So this is the Aboriginal Medical Centre that I work at Charleville. It's an Aboriginal community controlled, community run organisation. We have quite innovative ways of delivering healthcare. This is an ophthalmology van with an ophthalmologist delivering cataract surgery in the back of a semi-trailer. This is the centre here. It's quite a hot place, and it's very isolated. It's what we call a comprehensive primary healthcare system, and it's owned and governed by Indigenous people. This is the last slide. So just to give people context about the bigger picture of things, leadership is really important for transformative change. Partnerships with Indigenous communities. We're trying to think about who we're recruiting in terms of making better doctors and better health services for all, curriculum and assessment is only one aspect. Advocacy is very important, and we hope that the transformative change through the education opportunities that we give through teaching people about racism, that they can be better advocates to collaborate also with marginalised populations everywhere. And we also want to celebrate the successes. So that wraps it up, and I'm happy to take questions, and hopefully I was on time.
Excellent timing, Shannon, absolutely. Just for the record. Yeah, please, any questions? We've got a couple of minutes. Certainly, we'll be available at the OzTREKK booth. And Justine, hi Justine, good evening. Justine is the Canadian-based regional marketing manager for Griffith International, and she's based in Guelph and is a wealth of information on all their programs. So I assume Justine will be available at the Griffith booth as well. So please use the chat. I've got a couple of questions.
Aside from medical education, what do you say are the issues that should be addressed in the Indigenous healthcare? So we've got a question here from Eric. Aside from medical education, what would you say are the issues that should be addressed in Indigenous healthcare in Australia? Eric, one of the biggest things that we need to do is trying to improve access to healthcare. So if you're an Aboriginal person and you present to an emergency department, regardless of where it is in Australia, if you identify as being Aboriginal and or Torres Strait Islander, Indigenous in this context, you're less likely to get a diagnostic investigation or treatment, even though you got 8 times the burden of disease. So what we're trying to do is how do we improve systems that take better care of Indigenous peoples? And that's really bang for buck, I would think.
Excellent.
There are lots of other things. But, yeah.
Well, thank you, Shannon. That was fantastic. The similarities with the management of First Nations healthcare, the similarities are many between our countries, as you pointed out, and it's a big reason why the Australian medical schools are certainly appealing to Canadian students. So thank you. That was fantastic.
So
Thanks
similar,
everyone
yeah.
for joining.
Look forward to it. Thanks, Chris.
Yeah, cheers.
Thanks,
Thank
Justine.
you.